Hello, everyone. Thank you for joining us today. My name is Lucy Railton. I'm the Vice President of Marketing at Drummond, and I'm excited to welcome you to this informative session on preparing for the upcoming regulatory changes outlined in HTI-1. Everyone knows health IT regulations evolve and can sometimes be difficult to interpret. With that in mind, today's session is designed to help you build a strategic approach, ensuring compliance and readiness as we look forward to 2025. I'll take a moment to introduce today's speakers. Timothy Bennett is the Director of Healthcare Initiatives at Drummond. Hi, Timothy. He leads the development of new testing and certification programs focusing on interoperability and the HL7 fire standard. He previously led the ONC Health IT accredited test lab at Drummond and has been involved in the testing of electronic health records since, well, we don't want to say how long, and is a governing board member of SHIFT, which is a healthcare task force of industry stakeholders focused on ensuring fair and impartial interoperability. We also have Bob Bryan. Hi, Bob. He's the Senior Director of our Health IT Advisory Services at Drummond. He leads the team and provides health IT organizations with consulting services to help them effectively and efficiently plan for and achieve compliance with the ONC Health IT and other compliance requirements. Before Drummond, Bob oversaw solution delivery for clients in healthcare, financial, retail, and government sectors across North and South America. Before we dive in, just a few housekeeping notes. We will have a Q&A session at the end, so please feel free to submit your questions throughout the presentation in the comment or chat box on the right-hand side of your screen. This session is being recorded, and we'll share the recording with any materials with you afterwards. With that, I'll hand it over to you, Bob and Tim, to get started.
Great. Thanks, Lucy. Well, Tim, we're back together to talk about what the next year holds for our customer base and for others out there in health IT. We're just about through the first year of HTI-1 with most of our customers focusing on the B11 DSI rule, which was the main deadline. But it'll be interesting today for us to talk about what is involved with the next year and sort of what implications potentially beyond HTI-1 our customers should be thinking about as well. What are your thoughts kind of going into this presentation today? And
yeah, I'm looking forward. I always enjoy our chats, Bob. And 2025 is looking to be a interesting year, I think, for developers, EHR developers, and really developers across, I think, the healthcare continuum. So I'm kind of encouraged and excited about some of the new rulemaking, and so I think we'll get into that today. But obviously, we'll be focusing on the HTI-1 and what developers, I think, need to have top of mind as they close up this year and start thinking and planning about what is important next year.
Yeah, that sounds good. Year 2 of HTI-1. It'd be good to take a look at the timeline. Just in terms of what we have. I know my team's been working closely with customers on the year-end 2024 deadlines, specifically B11 and G10. Right. A lot of customers had the G10 area taken care of. But I think the main thing that sort of has implications down the road are the base URL updates that are required to comply with the standard for publication of that information. And I know you've given some thought to that too, just from the perspective of your heavy involvement with the fire standard and how that plays out on the market.
Yeah, probably not a whole lot of updates to the G10 fire APIs here in HTI-1, some tweaks. Like you said, I think one of the interesting caveats there is the the publication of the URL service URLs there. And, that's kind of a precursor to some really interesting work that's starting to go on, particularly around a national provider directory, which, we won't really get into that in necessarily in this webinar. But there's some interesting things here in HTI 1 that are kind of laying some foundations for some future rulemaking and some future technology developments that are going to enable a higher level of interoperability.
Yeah, I think they've laid the groundwork for better discoverability of these endpoints. Yeah. With the G10 maintenance requirements. And then that really plays into the increased focus on information blocking, with more regulations out there on it, and a recent blog from Dr. Tripathi really stressing the fact that this is an important area that ONC is going to be, or ASTP ONC is going to be looking at closely. So certainly important that people have that done at the end of this year. But today we kind of want to look into 2025, where we've got all these deadlines that, interestingly enough, in the proposed rule, when HTI 1 first came out, many of these deadlines were in 2024. They were one-year deadlines. And I think based on the feedback that the ONC received, they decided to push most of them out, except for B11, where they felt there was some urgency around getting a good rule in place to manage AI solutions. But the rest of them got pushed into 2025, I think, because a lot of the feedback was we're going to need 2 years to do this stuff. Well, the first year's gone now.
Time flies.
Yeah. So the rest of these deadlines are at the end of this coming year, 2025. So we can get into each of them today. We've got, US CDI version 3 and the minimum code sets that are related to that. We've got the new insights condition, which is a new type of reporting that's going to be required. We've got changes to the electronic case reporting rule, F5, for public health. We've got demographics changes. And then we've got the patient requested restrictions area as well, which is an interesting one under the E1 criterion. Plus the normal updates to standards, which we typically see whenever we have a new rule. But then the end of 26, of course, we've got electronic prior authorization coming, at least under the CMS rule that's out there. So what's been your thinking on that deadline that's out there 2 years from now for EPA?
Yeah, well, there's no rest for the weary when it comes to developing health IT technology, right, Bob? So, there's certainly the HTI 1 deadlines, in 2025, but, hot on the heels is the next round of rulemaking. CMS already has a final rule that they published earlier this year, which, it establishes 2027 into 2026, beginning in 2027, deadlines for the payer community to roll out support for a upgrade of electronic prior authorization based on FHIR standards. We'll get into that sort of later on in this webinar. I think we'll talk about that a bit, because really, that shows up in the HTI 2 proposed rule from ONC as well. So establishing some criteria for EHRs to sort of develop the provider side of the prior authorization conversation. And, my thoughts here, and we'll get into them a little bit more later, is that even though developers have things to do in 2025 for HTI 1, you can't really afford to sleep on electronic prior authorization and just push that off to 2026. You really have to kind of get started thinking about it, planning, and being strategic about it in 2025, and try to, I think, work that into some of your development plans as well. So anyway, those are my sort of top of mind thoughts about the about this roadmap.
Great. Well, let's get into some of the specifics of what we're looking at for next year.
Yeah. So, Bob, certainly I think one of the biggest changes yet for the HTI 1 deadlines in 2025 that remains is the support for US CDI version 3. And, and raising the core data set to a new floor, to a new version. And of course, in HTI 2, there's US CDI 4 that'll be coming down the line. So, what are your, maybe you can elaborate, Bob, a little bit on what developers need to, understand about, US CDI version 3 here.
Yeah, it's, as this slide notes, there are both new data classes and new data elements. And actually what this slide doesn't mention is that there are also data elements that have moved around between classes. So it's not just addition of some new things, but it's reorganization of some of the data in the standards. So, you're kind of ending up starting at the data layer, but much of this pushes up into workflows and UI, and depending on how products have been designed. So really some significant data changes, which affect multiple criteria. So customers will need to be, and actually not just looking at the data changes in terms of what US CDI version 3 says, but also looking at the code sets which have come along in these standards. So, it's significant changes at the data level. It ultimately also will drive up in terms of people's understanding of how to use these things. And I know you've looked at code sets kind of in the context of how they affect electronic prior authorization and their relationship to fire and future potential EPA requirements. What are your thoughts on implications of these changes as we get started this year?
Yeah, ONC has spent, Bob, they spent a number of regulatory cycles here trying to bring some alignment and continuity with code sets, value sets, establishing things like SNOMED, RX norm, LOINC as some of the standards in code sets that need to be supported in the EHRs. But we really haven't seen that to the same degree in the payer space. And of course, payers still use code sets and things like that. But really, when we start looking ahead to these fire standards that are going to enable a greater degree of interoperability and data exchange between providers and payers, it's going to be a challenge, I think, and it's going to be some interesting times to see what kind of alignment we see between payer solutions and provider solutions of health IT in terms of how they handle code sets, how they're aligning, and with potentially EHRs having to have electronic conversations between different payers. Are the payers across the board going to speak, so to speak, the same language that the provider is? And so, in terms of medical terminology, so I think terminology is going to be, an interesting thing as we start to really shine the spotlight on real interesting data exchange across the care continuum between providers and payers, and between different providers as well. So,
yeah, and it reminds me that we did in HTI2 see some criteria that payers can actually certify to.
Yeah.
Which will start to bring these communities maybe more together on these standards. They're at least as proposed, they're voluntary at this point, which is consistent with the whole ASTP ONC program. But I guess the question will be, what will CMS do, and will they implement some connected enforcement? And I think we don't know yet. But hopefully the whole community will see the benefit of complying with these standards in order to enable the path to prior authorization and other types of transactions that will come into the interoperable community.
Yeah, sure.
It is worth noting, just for health IT developers that are certified, that this migration to US CDI version 3 affects a whole set of specific criteria. So this creates a situation where, in terms of planning, the project to move to version 3 needs to be planned and then drive all the way through testing to confirm, for the purpose of the standard attestations that are done to ASTP ONC, that all of the specifics of these criteria are all still satisfied, and that the developer can remain compliant. I know we have some standards behind these two, particularly G10. And I did note that, coverage information is one of the new data classes, and that's probably a common thing that is in most certified health IT today. But nevertheless, it's specifically required as a class now with specific data elements behind it. And a last note, which is related to the US CDI area, but has specific changes of its own, are this demographics and observations criterion A5. These updates are sort of driven by the US CDI version 3 data elements, may be supported in many EHRs today, but of course the specifics of the data elements and the code sets that are behind them all need to be addressed with updated compliance to A5 this year. So that's just one specific area that's been sort of separated out with an update that has to be satisfied by the end of the year.
So Bob, as we kind of go to the next topic here, the insights conditions, the new reporting element here in HTI2, I'm not as elbows deep into this requirement as probably you are. From a little bit on the outside looking in, it kind of feels very real world testing ish to me. And I'm just curious, is, compare, contrast, if you will, what is this insights condition reporting, and how do you think, what do developers need to have in mind as they're kind of approaching this new requirement?
So a couple things, and I'm glad you mentioned real world testing, because a lot of people kind of ask, is this just the same as real world testing? So hold that thought. But the first thing I would point out is there's a threshold on who this condition applies to. And that is whether the developer supports more than 50 hospitals or 500 clinicians. Generally, we've seen with a lot of our EHR customers that the ones that are in the ambulatory space tend to be over the 500 clinician level. But at any rate, if you are under those thresholds, the condition doesn't apply to you.
I see. Okay.
But if you're over, to get to this question about how it compares to real world testing, I think of real world testing as qualitative reporting, in the sense that you're showing that your customers can do the transactions that are required under the certification criteria, the certain transactions that are identified for real world testing. So you're trying to show essentially a set of tests, based on real world activity, to basically prove that your system is continuing to do the things that you're certified to. The insights condition is more quantitative, because the ONC is trying to measure the volume of usage of these functions that they're requiring you to certify to. So there can be some crossover between real world testing and insights reporting, but they're kind of doing two different things. And the rule's interesting because they want you to report as much of the transactions as are possible under the specific transaction areas, specifically G10, E1, and F1. That there are some specific areas they're asking you to report on. In some cases, it's kind of a significant stratification of data that you need to build out and show. And they want you to show as much of you as you can for the calendar year. And if you can't show all of the quantity of transactions that you do, then they want you to show what percentage of your customer base you covered, so that they can extrapolate to the full volume of transactions that they think are going on with certified health IT across the country.
So to be clear here in my mind, Bob, this is a requirement for the developer themselves, not for their provider customers, right? So
right.
So the developer who has all of these, provider customers, hospital or clinicians, will collect this reporting data from across their customer base to some degree, and they'll submit the reports to, I guess, to ONC or to some or perhaps their certification body. I guess is that how that kind of works?
Right. And there's even some breakdown around the number of customer instances that they're reporting on, that's required under this. So yes, it's directly on the developers.
I see.
But it involves their customers, and could potentially involve some legal issues around access to the data and agreements with customers to be able to the ONC does not want proprietary data per se reported to them. but nevertheless, depending on the scope of customer agreements, there may be some issues there that developers need to work around.
Mm-hmm.
And actually, there's one last thing that's really important here, and actually, we should go to this next slide.
Oh yeah, I was going to ask you about when are this reporting supposed to begin?
Yeah, technically, the first report is not due until July of 2027.
Oh, okay, wow.
But the data collection period is 2026, which means by the end of next year, developers need to be ready to start collecting the data. And they're going to be looking at the full year of data to come up with these quantitative measures. And this rule's been rolled out in 3 phases, but in terms of quantity, I would say over 50% is in the first year, and then like another 30% in the second year and 20% in the third year. So really the big deadline is the end of next year to be ready to start fully collecting all this data from customer instances.
So you got to turn that faucet on in 2026. So
yeah,
you got to have the implementation done next year to be ready for that. I see.
Right. We probably should talk a little bit about public health. The F5 had significant changes. The electronic case reporting rule in HTI 1, and a lot of developers are already certified to F5, so they'll need to update this. And it'll be important to look at the expansion of the use cases that need to be covered, and there's new standards that apply here too. And depending on how HTI 2 plays out, there's a significant amount of new public health related criteria in HTI 2 as well. So I do think as developers make these changes, they'll need to be thinking about what's next, depending on when HTI 2 becomes final and what's in the final rule.
Yeah, I think Bob, we'll start seeing sort of the downstream effects of the COVID pandemic and how it's affecting public health and regulations that's coming out of that, lessons learned, so to speak. So I think we definitely see that in the proposed rule for HTI 2, but here in HTI 1, this work with electronic case reporting has been kind of a long, slow burn developing and becoming more mature. So I think it's finally good to see that it seems like it's potentially arrived now.
Yeah, I mean, there's both CMS requirements for this functionality. There's scoring based on it. And then there's a myriad of state requirements that are arising for reporting, which this ECR standard enables. So even I think there are a fair number of developers out there who may not be certified to F5 now, but do need to move in that direction and comply with the new rule, and then potentially be ready for whatever comes in HTI 2.
Hey, Bob, before we get too far downstream from the insights conversation, I think there's been a couple of questions here around insights. You want to tackle them now, or do you want to kind of wait till the Q&A later? What do you think?
We could talk briefly about a couple insights questions now, if you think that would be good.
Yeah, there's one question: is the insights tied to the MIPS reporting of providers only? Do you have a idea around that? Those are ready?
Not that I'm aware of. It's a condition of certification for the developer. So it's something the developer needs to do to maintain their certification. But it's primarily really intended, I think, for the ASTP ONC to assess the usage of the functions that they're including in the program.
Right. Yeah. Maybe get some insights, no pun intended, on how effective maybe some of the regulation is, and it's how it's being used and to what extent. Yeah.
Yeah.
One other question here too around insights. Maybe can you, Bob, speak a little bit more about what you mean by transaction data?
Yeah. So there are some specific types of transaction data, and we don't have time today to get into all the details of it. But specifically for G10 Fire, they're looking at things like the numbers and types of applications that are connecting to the G10 API, including identifying the purposes of those applications, things like that. And then they gradually add some more transaction requirements from year to year. But as I said, I'd say 50 to 60% of those transaction requirements are in the first year. And they're specifically related to connections being made both to the G10 API, to the patient portal under E1, and then a little bit of specifics around the numbers of immunization reports that are being done under the F1 rule. And there's more detailed breakdown in the rules. We're working through that, starting now to work through that with our customers so that they're basically getting their reporting capabilities up to speed and know that they're actually collecting all this data by the end of 2025.
Yeah, and Bob, I think at the not being able to really dig deep into here, but at the end of the presentation, there'll be ways that attendees here can reach out to you and maybe have a more in-depth conversation about some of these things.
Yeah, absolutely.
So shall we move on to patient access?
Yeah, let's. This is an important one to touch on. I know you've been involved in lots of discussions about control of patient data. This rule is interesting to me because it's fairly limited in terms of what it's requiring this year. It's just requiring this internet-based method to enable patient requests. But at least from an ONC compliance perspective, that's all it's done. So if you're certified to E1 now, you need to add this capability for patient requests. But that doesn't mean there's not more to do. Because, for one thing, we know there are some state laws already out there that are specifically, going beyond the request and specifying what you need to do with the request, that you actually need to restrict the data in some way. ONC is not saying that under their rules, but they've put their toe in the water on this in order to enable the request process. And then it also plays into the HIPAA privacy rule, which I think has always had a requirement for some sort of a request process. And the ONC is just basically saying it needs to be operationalized in software if you're certified under our program. But the downstream workflow in terms of handling these requests, that is open to product management decisions, but it's affected by a number of regulatory requirements outside of the specific ONC requirement here for a request.
Yeah, this is, you're right. It's kind of the sort of ONC sort of dipping a toe in the water. And this water is not a small creek. It's kind of an ocean. You're right. I've spent some time, working in the industry with other experts around patient privatized data. How a patient can restrict access to their data, and how that access maybe follows their data around. We're rushing sort of headlong into, this brave world of being able to share patient data, across providers, across the care continuum, and that's, definitely needed. That's going to improve patient outcomes and hopefully improve the patient experience. But it sets up somewhat of a concern, I think, to providers and other folks that sort of are entrusted with patient data. And, you kind of have some patients that don't really feel like any of their data is private. They're willing, for that data to be shared. They show up in an emergency room somewhere. They certainly want perhaps those providers to know about their health data so they can get the best care possible. But there's certainly some patients that have privatized data that they just don't want to be shared willy-nilly, and there really isn't a standardized approach right now to sort of allow patients to granularly pick which elements that they want to share and which elements that they want to keep private. And for patients like that, they kind of experience right now, it's either a full opt-in of sharing everything or don't share anything. And that can set up some equitable healthcare concerns for a patient who might have some privatized data that they don't want shared, and they're stuck with not being able to share anything. And so they'll show up at a emergency room, and perhaps that provider doesn't know anything about their health data. So there's a lot of work to be done here, Bob. And I think this is, again, kind of like some other things in HTI 1. It's sort of the beginning, tip of the iceberg of things to come. And of course, these are complicated scenarios that I'm kind of presenting here, but this is real world stuff and things that really matter to people. And it's something that eventually we'll have to, be able to tackle. I remember, Mickey Tripathi at one point standing up and saying, this is a can that's been kicked down the dirt road for a while now in health IT. And, folks have stood up and raised their hand and said that they've been part of kicking it down the road. But it's difficult. It's hard. It's not just technology. It's also policy and law and things like that comes into play. So I think this will be a spotlight to come.
Yeah, I don't think the rule even really says anything about the
No.
granularity of the request.
Well, the ONC regs has had, granular tagging of data and CCDs and other things for a while now. I think it's the B7 and 8 criteria, I think, if I'm remembering correctly from my days in the test lab.
Yeah.
But so some of the technology is there, some of the ways to tag this data is there, but operationally, it's been something that's been difficult to sort of do in a standardized way, and so there's still a lot of work to be done there to standardize it.
Yeah,
but that work is ongoing. There are people talking about this. There are people that are engaging this. Drummond's involved with an industry group called Shift, and we're have a passion about, this part of how patients access and how they can privatize their data and how that can be shared in an equitable way.
Yeah, I know there was some specifics on tagging in the proposed rule, and then the ONC took that out. So
Yeah.
they just didn't want to go down this road yet, and I assume it was because of some of the complications you're alluding to.
Yeah, and it's not an HTI 2 either, so
Right.
it's still a big TBD.
I know we could probably talk for the rest of this hour and beyond that on this topic, but while electronic prior authorization is not an HTI 1, I think it's important that we get to this topic today. What advice do you have for EHRs that are looking at prior authorization, and thinking about the CMS deadline that's out there 2 years from now, already in place, and then the proposed HTI 2 deadline, which aligns with the CMS requirement? What do you think developers should be looking at now?
Yeah, I think that this is a relevant conversation for this webinar because we're trying to get developers to think about what they have to do in 2025. Of course, that's they got things to do to be compliant with HTI 1, and that's going to be a priority for them. But these fire standards around electronic prior authorization that's coming down the road, that's already in motion from CMS and the payer world, and now, as you mentioned, ONC is proposing for that to be applied to the provider health IT, EHR developers, and other health IT developers that are going to be developing provider solutions. These are perhaps some of the most complicated technical requirements that's come down in rulemaking in all of my time since 2020. Since 2010, but certainly since the Cures rule in 2020. And my advice here is you can't wait. I know there's things to do for HTI 1 in 2025, but my advice is for EHR developers, you got to start looking into this in 2025. Start planning how you're going to engage with these HL7 fire IGs, implementation guides and standards, and how you're going to approach beginning to enable your providers to benefit and greatly benefit. I think the challenge is going to be large to implement this, but the impact and the benefit to your provider customers are going to be huge. I've seen numbers thrown out there that the way prior authorization is done today, and certainly if you have provider customers, you know this, they have large staffs just devoted solely to just doing this manual prior authorization workflows, and the cost I've seen is $17 billion to the healthcare space. I mean, that's billion with a B. Huge costs, and lots of resources are applied to this. For providers, and the dream and the hope of electronic prior authorization is to get the machines to talk to each other between the providers and the payers, and let the machines do as much of the processing of these prior authorization requests as possible, and really streamline that and make them more efficient, make the time to get back a approval or a denial much quicker, to hopefully improve the patient experience, potentially save lives, so people aren't having to wait to have a really important treatment or surgery or whatever. So the payoff is going to be big, but the challenge is equally big, and it's just not something, Bob, that I can with a good conscience say you can put this off to 2026 and get started on it then. And so that's, I think, a recipe for really getting behind the 8 ball.
Well, maybe it would be good to take a look at, just talk a little bit at a high level about the how the use cases break down, and then how that plays into starting some testing early.
Yeah. I can kind of do a little brief overview here, and then and talk about some new Drummond initiatives that I've been working on that I think is going to help IT developers begin to tackle the complexities of implementing these fire standards. So there's basically 3 main fire standards that sort of supports the electronic prior authorization workflow. The first one is called, essentially it's called CRD for short. It's the discovery of the coverage requirements, and an EHR would sort of use another fire standard called CDS hooks, which sort of hooks into your CDS, your clinical decision support implementation, and it kind of fires up whenever there's a procedure or surgery or some kind of treatment, lab, imaging, or whatever that might require prior authorization. It will fire off to that patient's payer, to their system, a simple query for this patient, for their health plan, for this treatment, lab, whatever it is. Insert your terminology value set, code set of choice there.
Right.
Is prior authorization required? Yes or no? And that sort of comes back. And if it's no, then then you don't have to worry about that anymore. But if it is yes, then
if you got the codes right.
If you got the codes right, yeah. And that's getting back to the terminology kind of discussion we had earlier. But if prior authorization is required, then as probably most of our audience knows, the providers then have to understand what the documentation requirements are that have to be submitted with the prior authorization request for approval. And that's where a lot of the serious manual work happens. That's where their staff is hitting all of these websites and trying to figure out what the documentation requirements are, and there may be back and forth with the payer on that. But here, what the payers are being required by CMS to do is to sort of make those documentation requirements accessible through a FHIR API request. And so once a prior authorization is said is needed, then the provider system, the EHR, can then get a template, a document, a questionnaire in the form of a FHIR standard that they can then electronically complete, fill out all the documentation requirements from the patient's record. Perhaps there's some manual additional notes that the provider has to do. That's going to be on a case-by-case basis, but the idea is that a good part of that is already in the patient's record. Maybe there's an imaging attachment that has to be done there, or some labs or whatever, but all of that can get bundled up. And then the final step is the prior authorization support, which is basically just the provider going back, submitting the official prior authorization request with the bundled documentation requirements, and then being able to get that approval or denial or whatever decision back from the payer. And that's in a nutshell going to sort of streamline and make this whole workflow electronic. Now, of course, there's always going to be outliers. It's still going to have manual people involved, but if you can trim off 80% or more of the prior authorization requests and get them to be handled electronically, that's going to have a major impact for payers, but especially for providers and their bottom line.
And I gather there can be some significant differences between payers in terms of that second step, the documentation that they're looking for and what their coverage rules are, which seems to lead us to the question of how do you test with payers if you're an EHR developer that's building out this EPA workflow.
Yeah, and so that's something that we've been thinking about at Drummond for a while now, because again, these are complicated multi-step workflows of fire standards. You have provider systems like EHRs that are going to be connecting directly with payers, or perhaps through a QHIN or some other intermediary that's out there. There's all of these sort of entities in the ecosystem out there, the health IT ecosystem. And it's a very complicated, multi-actor, bi-directional, messaging that's going on. This is way beyond the patient access fire APIs of G10. This is very much next level, and it's going to take a different approach to testing. Now, there's always going to be test tools like Inferno and others out there that that you can run against your implementation to see if you've implemented the standard before, and there's going to be certification criteria around that. Eventually Drummond will be doing those kinds of certification tests, but we know at Drummond what is needed is more than just conformance testing with a tool. I'm not going to spend a lot of time on this, but just understand that long before Drummond got involved in health IT testing, all the way back to the beginning of the internet being used for business secure data exchange purposes, Drummond was there helping other domains become interoperable, like supply chain and the B2B world. And Drummond was there running interoperability tests where we facilitated bringing together competing implementations of these standards so that they could test directly with each other. And that way they could work out interoperability issues beyond just, implementing standards is definitely important. Everyone standardizing on the same way of doing things, that's the absolute first step. But interoperability is more than just implementing a standard, because people can look at a standard and they can interpret it differently, and then there's all kinds of other things in the IT stack that can present challenges to interoperability. And it's really only when you sort of start to bring the implementations together to test that you really find those out. And so that's what we're doing with our Fireplace initiative at Drummond, is we're going to create this sort of community of implementers that will be EHR developers, provider systems. We're going to bring payers together. We're going to bring other entities together with their implementations and facilitate and curate a way that implementers can first learn how to implement these complex standards together, and provide them with partners that they can test with as they're developing. Because if you sort of wait until the deadlines in 2027 and roll out your system with really only testing with a test tool like Inferno, and never really having tested with another system, a real payer system, or payers testing with a myriad of different EHRs, expecting those things to actually work and work at scale in the real world, that's a pipe dream. And so we know this. We know that there's going to be value that's going to be needed for the implementer themselves to have ways that they can test and improve and make sure that their products are going to work, and really help realize the massive potential of
and it looks like with just the complexity, particularly of that second step across different payers, that having this ability to do ongoing testing during development will be a real value. And it's a little different than some of the other interoperability rules that have come out in the past. This one, you've really got to get hands-on with the players in the ecosystem, and for providers.
Yeah, and that's the thing. Well, Bob, we could talk. We and we probably will. We'll probably have another webinar at some point here in the future where we just talk about Fireplace. We talk about
Right.
electronic prior authorization and how Drummond is planning to provide technology and methodology and services to help our customers. But we've only got a few minutes left here. We got a lot of questions here in the Q&A here. So why don't we get to a few of those in the last few minutes we have here?
Yeah, I saw there's a question that just came in about prior auth, about whether it's for all services or just ERX.
Yeah, I can. So we're talking about clinical prior authorization. Pharmacy and drug and medication prior authorization is kind of its own separate thing. And so the prior authorization that we're talking about here, that's part of the CMS 0057 rule and the HTI 2 rule, is clinical prior authorization. And so that's a good distinction. That was a good question.
And I know we had another question about F5, just to go back to that topic about whether this will be mandatory for the next year or the following year. It's a little bit complicated, but it's not technically mandatory as far as the ONC is concerned. Of course, the ONC is a voluntary program. But there are growing CMS requirements that make it near mandatory, certainly for certain types of practices. And then in addition, there are growing state requirements for this type of case reporting. So it's one of these areas that's more driven by CMS and state requirements than it is specifically driven by, it's not part of base EHR, for instance. But nevertheless, the requirements on providers to be able to do this type of reporting are growing. So that's really where the requirements are coming from for EHRs to look at F5. It grew out of the pandemic and has been a continued focus. And then we have a whole new wave of public health rules that came in HTI 2. So we'll see what we get there once that goes final.
Maybe we have time for maybe one more. Bob, looks like Monica had quite a number of questions around US CDI and code sets, value sets. Can't get to all of them, but maybe you can.
Yeah, I would say to get into the specifics of the code sets is kind of beyond the time that we have today. But I'd be happy to talk offline about that. There's a bunch of details, obviously, in the standards. There's specific code sets that apply to specific data elements. And then there are US CDI data elements that don't have any code sets. So it's left open to the developer. But unfortunately, that's a level of detail that takes a longer conversation. But anyone who's interested in that, please reach out to us. And we're at the end of our hour now. So thanks to everyone who joined today. Hopefully the conversation was helpful. And I'll pass it back to Lucy.
You're on mute, Lucy. Turn on your mic.
Got to unmute myself. Sorry about that. Thank you so much, Bob and Tim, and everyone for taking time out of their day to join us. On the screen, you'll see 2 QR codes. One is to book a free consultation with Bob to address your HTI-1 questions. Monica, that would be a great way to get all of your questions answered. And the other is to register for our upcoming webinar on December 10th with John Vukovic and Bob again, talking about meeting new standards, state of predictive DSI. You can also visit our website, drummondgroup.com, for more ways to connect with us. With that, I hope you have a great day, and we look forward to seeing you on the next webinar.
Thanks, everybody.